Thank you, Dr. Rahul, for giving me an opportunity in this colorful IC. So, my topic is approach to yellow macular lesions. The most common yellow spot that we see is actually the physiological spot, which is macular lutea. The yellow color is due to the carotenoids lutein and zeaxanthin, which is a very important protective role in our eye. But we also see a variety of pathological yellow lesions of very wide ranging etiology, and we'll try to look into some of this in more detail. So, we will start with drusen and hard x-rays, which are the most common yellow lesions that we see. And very often, for the beginner, there can be little doubt as to whether it is a drusen or a hard x-ray when they see an yellow lesion. Drusens are typically dull yellow, randomly spread, whereas hard x-rays are more bright, well defined, and see in either clumps, circinate, or stellate patterns. And definitely OCT help us to know their location, which is sub-RPE or subretinal in drusen, whereas it is intraretinal in hard x-rays. While drusen is a hallmark of age-related macular degeneration, hard x-rays are commonly seen in vascular diseases due to various reasons. Now we look into drusen in little more detail, which is the first lesion that define AMD. So age-related eye disease study have classified drusen into hard, soft, and calcific drusen. It's not enough if you just see the drusen, we should know the implication. Hard and calcific drusen can predispose to atrophy, whereas soft drusen can precede PED and CNV, which is more ominous. In these patients, when you see such findings, we should give them appropriate advice in the term of lifestyle modification, avoiding smoking, use of anti supplements either naturally through their food or antioxidants, and monitoring their vision with Amsler grid. And with the help of OCT, we can evaluate these drusen's in more detail. And this is important because the various biomarkers for progression to advanced AMD are the drusen size, area, height, and length. If there is increase in the height, it is more risk for GA, geographic atrophy, whereas increase in the length is a risk for CNV. Now, there are other yellowish lesions that may not be recognized always. You can see very fine dot-like yellow lesions. And on OCT, you can see that it is actually internal to the RPE, looks like subretinal granular hyperreflective material associated with a thin choroid. And this is what we see in pseudodrusen because it is under the retina and not under the RPE or subretinal drusenoid deposit. And this is another drusen, which is larger, and it is under the RPE and with thick choroid, which we call it as pachydrusen. It's important to identify because pseudodrusen can predispose to neovascular AMD, whereas pachydrusen predispose to PCV and CSR. Drusen is a common finding in those above 50, but when you see drusen-like lesions in those less than 50, let us give little more attention. It can be cuticular drusen when there is numerous small dot-like lesions, and this is in the spectrum of AMD. Familial dominant drusen typically has a radiating pattern and it also involves nasal to the disc. It's basically a genetic condition. And these large colloidal drusen looks large, but they generally have a good prognosis. Again, when you see extensive drusen-like deposits, we should also look into the systemic status because they can be associated with renal problems, SLE, chronic inflammations, etc. And one point to differentiate it, they may not show hyperautofluorescence on FAF imaging. And any patient less than 50 years with significant drusen, please evaluate their renal status. Now we move on to hard exudates, which typically seen in circinate pattern and can be in wide range of etiologies. This was in a case of DME, this was RVO, this is PCV, and this is AMD. So wherever there is capillary endothelial damage and breakdown of the inner blood-renal barrier, it can lead to leakage of the lipoproteins and formation of hard exudates in a circinate pattern. So not all hard exudates mean it is DME because most of these cases are referred as DME, especially if there is a history of diabetes. We should try to understand the etiology of the hard x-rays and then give the appropriate management. So this is a 64-year-old lady, came with blurred vision. You can see extensive yellowish lesions in the posterior pole. We were not sure FFA and OCT did not show any features of inflammation, but her blood workup gave us the answer, alarmingly high lipids, and with systemic treatment, she improved very well. Now we move on to the yellow lesions with subretinal fluid. These are three different situations. How do we proceed? The first case is a young male came with central scotoma. OCT shows subretinal hyperreflective material with a vacuole sign. FFA showed ink blot leak, no network on octa. So this is CSR with fibrin, which was giving that yellow appearance, and he responded to focal laser. This is a little more elderly lady with defective vision. There is subretinal hyperreflective material or SHREM. There was typical classical type of leak on FFA and ICGA, network on octa, suggestive of AMD with classic CNVM, and this has to be treated with anti-VEGF. And the third case is again an elderly patient. He was actually treated as CSR with eplerenone in US. So when he came to us, in the OCT, we could really pick up the findings of double layer sign, tall PED, hotspot on ICGA, and a network on Octa suggestive of polypoidal choroidal vasculopathy, and he also responded well to anti-VEGF. So yellow lesions can occur in AMD, PCV, CSR, and with multimodal imaging, we can definitely differentiate these conditions. We will move on to the next spectrum. Again, two different patients with a prominent yellow lesion in the macula. Second case, the lesion was looking little elevated with a lot of SRF. OCT in the first case gives us a full thickness retinitis, so most likely it's a toxoplasma. Whereas in the second case, you can see an elevated choroidal lesion with subretinal fluid with a contact sign indicating it is a TB choroidal granuloma, and both resolve with treatment. Of course, in retinitis, you get a scar. Granuloma may resolve completely without any residual changes. So inflammations, if it is more bright yellow and it is ill-defined and superficial, it is more likely retinitis, where if it is more deeper, little more dull yellow and well-defined, it's likely to be choroiditis. And definitely with OCT, it's not a big difficulty to differentiate the two. This is a young boy with multiple small yellow lesions, which was initially superiorly, then it became temporally, then it became more closer to the macula. OCT showed outer retinitis with the hyperreflective dots in the vitreous. So this, because the uveitic workup was negative, we diagnosed it as presumed diffuse unilateral subacute neuroretinitis or presumed DUSN. So when you see these retinitis lesions, we should try to differentiate and understand the etiology. Small punctate lesions can be Behçet's, DUSN. If it is large patches in the periphery, it is ARN. Full thickness lesion is toxo. Outer retinitis is more syphilis or DUSN, and inner retinitis is post-fever retinitis. And OCT again is useful. This is another patient with multiple, little more larger yellowish lesions, discrete initially, then became confluent. OCT showed changes in the outer retina, RB, and choroid. FFA showed early hypo, late hyper. ICG showed hypo. So this was actually multifocal choroiditis, and we should try to differentiate the etiology, whether it comes into the white dot syndrome or stromal choroiditis. The next spectrum, we have bilateral similar yellowish lesions with very characteristic hyper autofluorescence on FAF and hyperreflective material on OCT. Diagnosis is for sure it is autosomal dominant Best disease. This is another patient with multiple vitelliform lesions and subretinal fluid. This is in the same spectrum, but it is autosomal recessive Best retinopathy. So whenever we see such bilateral symmetrical lesions, younger age of onset, we should evaluate them for dystrophies. This again, as we can see, the typical flex either in the perifoveal or more extensively suggestive of Stargardt's, but we should try to differentiate them from drusen. Drusen is more round, whereas the flex are more elongated or pisiform. Mass lesions can also be seen as in this case and seen on the OCT with a kind of lamellar pattern, but ultrasound showed a hyperechoic lesion with shadowing, which was due to choroidal osteoma. And this is again elderly patient with multiple yellow lesions. You can see the typical lumpy bumpy appearance of the RP suggestive of primary vitreoretinal lymphoma. This is a young boy, unilateral high myopia, -9 with amblyopia. And this yellow appearance was due to the myelinated nerve fiber suggestive of Stratsma syndrome. And this is a triad of the syndrome. So when you see common retinal yellow lesions, it's a very common finding in the elderly, but in the young, it should be more significant. Try to characterize the lesion so that it will help you to understand the etiology, which can be a specific problem or non-specific like heart disease or rare conditions like masquerade, and a systematic approach is important. Before I conclude, I want to show one last case, which is a curiosity. He had bilateral retinal hemorrhages due to anemic retinopathy, and FAF showed hypoautofluorescence, which was expected due to the blockage from the blood. The hemorrhages resolved, leaving an yellow spot at the fovea, and it showed a hyperautofluorescence, and I did not know. Ideally, it should be blocking the fluorescence. So then I searched and found that this yellow spot is due to bilirubin from devitalized blood, and it is an endogenous fluorophore. That is why it caused hyperautofluorescence. Thank you.
Thank you, Dr. Lekha.